So good afternoon, friends. It was a very nice talk by Matthew. It is actually covered a lot of ground in a very short period of time. So use this as a stepping stone for reading up this topic, because if you don't understand phaco-dynamics, fluidics well, it will make it difficult for you to negotiate the phaco learning curve. So my topic is Capsulorhexis pearls. We know it is the most influential step in cataract surgery, in phaco surgery, and it is also the most challenging situation, particularly in the initial stages of a learning curve. And most of the complications happen that time. And actually, we can talk about phaco pearls. It can go on for about 1 or 2 hour course. But what I have decided in my presentation today is I'll just show you a few typical case scenarios. And if you happen to negotiate, you happen to encounter them in your during your phacoemulsification, it will be useful for you. So before I show you the videos, a little bit about the sizing. We all know that the rhexis size should be 5 to 5.5 millimeter, and you need to keep a 0.25 to 0.75 millimeter overlap of the anterior capsule for various reasons. I'm not going to that. But if you happen to encounter a small rhexis, here for example here, it may not be safe for you to continue with phacoemulsification, particularly if I'm dealing with a soft cataract or if I'm dealing with a very hard cataract. I need greater access into the lens matter, so I need a greater window, opening of the anterior capsule. So in this particular case, I decided that, I need to have a larger rhexis size. So I used the same cystitome to create a nick on the rhexis margin and then enlarged it. So this process can be done with a microrhexis scissors, and then you can use microrhexis forceps from the main incision or from the side port. Most of the time I use the cystitome in case if it is not an intumescent cataract. Then of course you need to have a proper grasp and proper purchase on the capsular flap. So cystitome did not work out fully here. So I had to re-inject OVD into the anterior chamber, took the ureter forceps, and then grabbed the anterior capsular pedicle and made a larger rhexis. So this is something which you need to do if you are dealing with a very soft rhexis. So this is the rhexis. If you are dealing with a small rhexis, the rhexis was completed. And this is after the secondary rhexis, and things went off pretty well. Now, this is another case. This was a very shallow anterior chamber. Patient had raised intraocular pressure, and it is an intumescent cataract. Now, when I did the rhexis, I was scared that I was not able to form the AC, and I was scared the rhexis may run to the periphery. All right, and these are the cases where we tend to make a little smallish rhexis, because if things are happening in the periphery, untoward things, then it is very difficult to salvage it, bring it back. So I made a smallish rhexis to be on the safer side. Now I need to make a larger opening here. Eye was extremely hard. So if I inject OVD into the eye, a cohesive OVD into the eye becomes very hard, and there is always a possibility of the uveal tissue prolapsing through the paracentesis tract or the main incision. So what I did in this case, and I needed to have a larger opening, larger rhexis, about 5.5 to 6 millimeters. So I just decided that I will not take the other recourse to the other options like passband vitrectomy to soften the eye, because it was a total cataract. I would not have seen the phaco tip what it was doing. So I used my phaco handpiece and did central phacoemulsification of the exposed area of the nucleus, and then went little behind the capsule. So now I have the rhexis, which is actually located in a deeper aspect of the anterior chamber, and you inject OVD, the intraocular pressure really doesn't go up, and you have a deep anterior chamber, not much of stress on the anterior capsule, and continue with the rhexis. So this one, if I had not employed this technique, then I would have, all these patients had received IV mannitol to soften the eye pre-op, but nothing had worked out well. So here, it does pretty well, and I get a decent rhexis for a safe phacoemulsification that you see here. Now, this was actually from time to time I encounter this problem, particularly when the rhexis margin approaches the inferonasal area. So that is the area where particularly people with big, peaked noses, deep set eyes, and drape reflexes. So here, if you see here, at one point I have perforated the capsule once again and initiated a fresh rhexis, and then there is a capsular tag. So sometimes it may be very minute, you may miss it, but in this case I knew that things were not very safe because visibility was compromised. So I injected OVD and then took that particular tag and converted into a rhexis. So at each and every stage of your phacoemulsification, whatever step you do, you must be very, very critical and scrutinize the findings and take corrective measures so that there's no cascading effect down the line and surgery goes on smoothly. So this is how I avoided this mishap. Now this was another scenario which happens from time to time, particularly when I was a younger surgeon. I mean, I have completed about 3 decades as a phaco surgeon on 20th October. So here, this is peripheral margin of the flap is the active margin. This is where the capsule is being torn. But if you see the inner margin of the capsular flap, so that is something which in this kind of cataract you don't expect any problem. But if the force dynamics are not properly employed, the inner margin, it is not an intumescent cataract. It doesn't have an inherent tendency to run to the periphery. But the inner margin may, it may go towards the outer margin of the rhexis, developing rhexis flap, capsular flap. And if they meet together, then you have a very odd shaped rhexis. So this is the way to overcome it. I put the whole capsular, the 2 lobules, upside down, and then and treated these 2 aspects, 2 different units as one single unit, and turned it around. And if I had done that, I would have got a very small odd-shaped rhexis, and again I have to go in with micro-rhexis scissors and forceps, and things would have become a little more complicated. There are certain situations we just cannot do anything about rhexis extension. Like this was a very young patient, silicone oil filled into the anterior chamber, into the posterior segment, very, very tense cataract, and it went out to the periphery. But I feel that if you have begun your rhexis well, and if it tends to go to the periphery, it is an iatrogenic tear. It is something which could have been avoided. And now we have a couple of, so the technique which we have been following, for donkey's ears, if it is a intumescent cataract, you make a small primary rhexis and then debulk the capsular bag. The primary rhexis should not be too small. If it is 2 millimeters or less, sometimes when you debulk with your irrigation aspiration, you may stretch the rhexis margin. And trypan blue stain rhexis margins are quite friable, quite rigid. I think Minu had done a very nice study which won a lot of awards on the effect of trypan blue on the capsular rigidity. So it may tear. So it is about 3 to 3.5 millimeter is ideal. If you try to make it bigger, the primary rhexis, it will run to the periphery and then you cannot get it back. So this is the standard technique I think most of us employ. And now here, for example, I'm showing you some of these unexpected problems. This is a fairly routine cases for most of us Indian cataract surgeons. Primary rhexis goes on pretty well. There's no issue. And then when I'm trying to enlarge the primary rhexis by giving a capsular nick, so let me check here. Here, okay, so now I'm taking the Varna scissors. I could have used the micro-rhexis scissors. So with the Varna scissors, if you see here, the scissors doesn't cut, it's like a forceps. It cuts and then, if you see here, it draws the capsular flap, and after cutting it, it draws it behind. So then I have just punched a defect in the anterior capsule. So it is a continuous thing. However much you pull it, you're not going to get a tear. There is no angularity in the capsular opening. So again, you have to make a fresh cut proximal to where the rhexis margin had ended, and then subsequently you do a 2-stage rhexis, and then it is, easy peasy. There's no problem, and it went off pretty well. Now this was another case where this shows the classical Little maneuver. This is a technique which Brian Little has described. We have done many courses together at various international meetings. So here, the primary rhexis goes on pretty well. There's leakage of fluid, the water cleft and vacuoles that is happening. So that is to be expected. But if you see the paracentesis here, it is pretty long. The inferior paracentesis, it is pretty long. And here, the relevance will be clear to you a little later from now. Now, when I cut this anterior capsule here, again I'm using the Varna scissors. So here it cut it and then it pulled it back. So you have a rhexis, a capsular flap which goes almost to the periphery. So it is important to inject the cohesive OVD not at the center but at the peripheral to where the potential rhexis tear might happen. So here I created a fresh paracentesis because it was, I think, a little deep set eye, and then the corneal tract was pretty long. So if you try to manipulate the capsule from the existing paracentesis incision, there will be a lot of overlocking, corneal striae, visibility will be, will be impaired, and there will be jerky movement. So please watch what exactly the little technique is about. Now I am pulling it. So okay, a fresh paracentesis incision is created just to get the rexis straight, and then using the rexis forceps, you grab it very close to where the rexis, close to the V, where the tendency was there to run off to the periphery. Again, it punches it here, but then again here, I'm pulling the rexis in the opposite direction. So the intended direction of rexis is this, but I'm now pulling it in the 180 degrees away. So once you see that rexis has started coming under control, you bring it to the center and then pull it radially. And like any other, rexis, microrexis, used Capsulorhexis. So again, this is an odd hourglass shape rexis that had happened. And so we used this time I took the microrexis scissors and then the forceps, and then it went up pretty well. So little technique is something that we need to be really familiar with. So basically, if you have a swollen lens, I would prefer to use IV mannitol. In some of these patients, I'm talking about patients where the lens is swollen, the AC is extremely shallow. And then at times I have done a past-line vitrectomy to open up to make the eye a little softer. And then OVD strategy, again, I use a very good quality cohesive OVD for rexis. Rexis I initiated, I use the cystitome and then use a two-step technique, as I've told you earlier. And then one stage rexis. So basically, since the time is over, so in summary, so stain the capsule whenever visibility is low, even if it is not in mature cataract. Pre-op IV mannitol in selected cases. You may aspirate a little bit of cortex with a needle before you start the main rexis. Always attempt a smaller initial rexis, two-stage rexis in intumescent cataract. Maintain the anterior chamber depth with cohesive OVD. Be ready to work from the side ports. Use appropriate instruments. Thank you very much for your kind attention. And before I wind up, can I have the last slide? I think that was before that. This one, yeah. So I just requested help for my onward journey in All India Ophthalmic Society. I'm contesting for the post of Vice President, online elections. Please cast your vote and support me. Thank you so much.